lidocaine, and our speaker is one of our own faculty members, Sean Curran. Sean, I don't know where you got his name. Where did you get your BSc?
Western.
But Western. Well,
MD Western.
You've mostly recovered from that. He actually did his anesthesia residency here at McMaster, and then after a couple of years of clinical practice, he decided to go on and did some more training in pain, and he actually ended up going to Australia, where he worked with Michael Cousins' group at Flinders, and took part in some graduate studies there before he came back, and he's been working in the pain clinic, initially actually a fair bit of work in Burlington, Credit Valley, and so on, and then joined us here in Hamilton a few years ago. So he now serves as our clinical teaching unit director at the group pain clinic, and has done a fair bit of work around education in pain. So Sean, thank you very much for this evening.
Thank you. So interestingly, I was expecting the usual crowd, which was a lot of non-anesthesia people, but it looks like, apart from Gary, yeah. So it's a lot of, my plan was to talk a lot about local anesthetic in terms of uses in the operating room, so maybe I'll minimize that. But that is my topic for tonight, lidocaine infusions for pain management. And re-advance the slides now. There we go. So I was just going to say my credentials, but Dr. Buckley went over those, so I won't go over those again. I have no financial disclosures. So the overview of my presentation, I'm going to talk about how local anesthetics were discovered, a little on sodium channels, and then lidocaine pharmacology. Clinical use of lidocaine, I was going to plan on talking about things, but I think I'll probably minimize that. Particularly, I'm going to focus on use in pain, and it's going to focus on neuropathic pain, so I just wanted to discuss neuropathic pain briefly. Talk a little about the evidence. I want to talk a lot about the toxicity of lidocaine, the concerns around use of intravenous lidocaine. Particularly, I was hoping Laura was going to come just to go over some of the treatments for that. I understand that there's some thoughts about, the cost is left about maybe trying to change some patients over to McMaster, so I wanted to talk about McMaster a little bit. There's a couple of published practical approaches to using lidocaine in pain, and I was going to go over what my approach is, and then I was going to discuss a few cases that I have, if time allows. So, since we're talking about local anesthetics, does anybody know what this plant is? It's from South America, and it's the leaves were used for years. Coca plant, you got it. So the plant was used for a mild stimulant. The leaves were chewed. It was used into tea. And then in 1855, it was cocaine in the form of something called erythoxylene was what did they call it? Isolated. And if you notice here, there's two different types of local anesthetic. There's esters and amides. And you can notice here in red is that ester bond, the CO, C double bond, O, the cocoa bond, which has a lot of effects of a lot of our medications that are shorter acting. And cocaine is an ester local anesthetic. It was first started being used clinically a few years later in 1884 when ophthalmologists were instilling in his own eye and checking with needles. And then first brachial-plexus block was in 1885. I won't go over too much. I was thinking about talking about brachial-plexus blocks, but I won't talk much about that. And then interestingly, in 1885, somebody named Corning was the first person to inject it into under the spinous process of a dog and then into a man. And then a number of years later was the first reported surgery under spinal anesthesia by Professor Beer. It was in Germany. So I went to Western, and this is Professor Paul Potter, and I took a course in undergrad, which was history of medicine. He taught us in med school as well. And I distinctly remember this journal he reviewed, and I could not find it. And it was entitled Hammer on Knee, Pliers on Testicles. And it was two dentists in the late 1800s who took turns at instilling intrathecally cocaine, and they hit each other, and they didn't feel any pain probably until a few hours later, and they published it. I couldn't find the article anywhere, so I'm not sure if Professor Potter made this up or not. It was quite interesting. So moving on to lidocaine, synthesized in 1943, and you notice there's no ester bond. There's a double bond, but there isn't the cocoa bond. So this is an amide local anesthetic. So this is the structure of the sodium channels. And interestingly, there's a little cartoon here. The little diamond in the middle represents the local anesthetic, and it crosses the cell membrane and accesses the sodium channel through the intracellular part of the sodium channel and blocks the channel itself so that ions can't cross. Interestingly, in our practice, we do a lot of regional anesthesia at St. Joe's, And I knew that clinically, and I read this in the literature, but until this week I did not know why this was true. If you get somebody to engage the limb after you block, the onset is faster. And the reason for that is the channel has to actually be open for the local anesthetic to occupy it. So encouraging the person to use their limb before the block, it actually increases the onset of the block. So local anesthetics, they slow depolarization by impairing the cells to be able to reach threshold for action potentials, and nerve conduction is blocked. So just as a cartoon, we see that there's a resting membrane potential of -90, and through ion pumps and channels, the transmitter potential will increase to a threshold of -70, and then there'll be hyperpolarization with an action potential, and then returning down to resting potential in normal situation. With the local anesthetic, which is along the hash line, this is not met, so there's no true action potential, and there will be no nerve transmission of the affected sodium channels. Another name for sodium channels are voltage-gated sodium channels. We see in the literature VGSC, and they act as a gate it opens and closes, allowing access of ions into the cells. And there's 9 subtypes, and they're classed on their response to a certain toxin, and they're 1.1 to 1.9. So there's 3 states of the sodium channels. There is, on the left is open with the activation gate closed. On the right is closed, even though in certain cartoons you actually see the gate closed. And the middle is open. And again, this is the only state where the local anesthetics have access to closing and blocking the sodium channel. Excuse me. So these sodium channels are all over our body: the central nervous system, peripheral nervous system, skeletal muscle, cardiac muscle, viscera, dorsal root ganglion, and the different subtypes have different expressions in different tissues and different concentrations. So the implications for these different channels are, as you can see, pain, epilepsy, arrhythmias, long QT, cognitive issues, and anosmia. Does anybody know what that is? What's anosmia? Can't smell, lack of smell. Very good. Thanks, Lydia. I knew I could count on you. And interestingly, each one of these sodium channels has a single gene that transcribes its expression. And there has been genetically engineered mice with knockout of those specific genes that code for those sodium channels. And 4 of those sodium channels, 1.1, 2, 5, and 7, these knockout mice, it's a lethal emission. So either in utero or shortly after birth, they die. The other sodium channels, there was a great table in one of the articles I was reading that went over all of the other issues that can have seizures, pain, dysrhythmias. So it's essential to have all of these sodium channels for life. Not only just knockout, but there can be mutations, and there can be upregulation and downregulation of some of these channels. 1.7 is known clinically to have different expressions. If there's downregulation, you can have congenital insensitivity or congenital loss of pain. And in fiction, there is a character in a very popular movie series. This guy is... That's it, the Girl with the Dragon Tattoo. So he apparently has insensitivity to pain, and he's very strong. I just wonder if he has anosmia or not, because he may have anosmia, which would be good for burying dead bodies, actually. There can also be upregulation of 1.7, and people have erythromelalgia, which is a burning pain in their limbs. It can affect either one or both limbs. Interestingly, NAV is another expression for sodium channels, voltage-gated sodium channels. 1.8 and 1.9, there's increased expression in nerve injury, which can increase spontaneous pain and spontaneous activity of sodium channels. There is preclinical work being done on specific sodium subtype blockers, but currently there's none in clinical practice available. So we have all these non-selective sodium channel blockers. Some of them are specific to sodium channels and some not. Lidocaine, dilantin or phenytoin, carbamazepine, lamotrigine, topiramate. Amitriptyline is both a tricyclic antidepressant, has an effect on sodium channels. Flecainide and mixolotine. So I'm going to focus on lidocaine and mixolotine, specifically for the rest of the talk for the most part. So lidocaine, again, there's the chemical structure. The onset is rapid with a half-life of elimination of 1 to 2 hours. And it's got poor oral bioavailability of 35% because of a high first-pass circulation in the liver, so we can't take it orally. Metabolism is 90% hepatic with active metabolites, and liver disease can prolong its action for a long period of time, 5 times. protein binding is moderate compared to other local anesthetics. So this is what I was going to talk a little bit about for people that aren't familiar with local anesthetics. So local infiltration, just briefly, it's used for sutures and superficial structures, for example, in the emergency room. It's used for topical, for eye surgery, for cataract surgery. We use it a lot in peripheral nerve blocks at our institution for shorter procedures that aren't painful afterwards if we want to have a rapid onset block and there's not much pain afterwards. We use it in epidurals when we're converting labor analgesia to surgical anesthesia for cesarean deliveries. But it's not used intrathecally because of concerns of transient neurological symptoms where patients have pain or they sometimes have strange motor symptoms, and there's certain procedures that are associated with it, so we just don't use it intrathecally. Intravenously, originally it was used for IV regional anesthesia or beer blocks, the same beer that did the first spinal surgery. And I'll talk a little bit about that just because it's similar to what's done in our pain clinic and some procedures. And that's also probably how we started using it for intravenous infusions for pain. So what the thought of this is, if you can replace the blood in a limb, whether it's a hand or an arm or a leg, with local anesthetic, then you can actually anesthetize the limb. So what we do in the operating room is we put a tourniquet on the limb, put an intravenous in the same side. We use a giant elastic band to exsanguinate and squeeze the blood out of the arm, inflate the blood pressure cuff, and then infuse high volume, low concentration lidocaine into the limb, and quickly have surgical anesthesia. There's some concerns about local anesthetic toxicity, but it's very effective. If you can put an IV in somebody and you have a tourniquet, it works really well. Lidocaine has started being used for something called enhanced recovery after surgery. We call it ERAS. I'll talk a little about that in the next slide. And then we also use it more recently in pain, specifically mostly neuropathic pain. So ERAS, excuse me, lidocaine was known to be an analgesic intravenously starting in the 60s as case reports. And then in the 1990s, there was the first clinical trial that looked at specific surgical procedures that they're given infusions of lidocaine and the effects postoperatively. And this has progressed into lidocaine infusions being part of ERAS. There's been a number of meta-analysis looking at the effects of this, and this is one of the meta-analysis saying that there's decreased duration of ileus, hospital stay, decreased postoperative pain, and nausea and vomiting. There's more evidence in open procedures than there is in laparoscopic procedures. You can see the colors there, moderate evidence for open and low evidence for laparoscopic procedures. You can see the doses there. Usually we use 1 to 2 milligrams per kilogram bolus dose up to 100 milligrams, an infusion of 1.5 up to 3 milligrams per kilogram per hour, and that's based on lean body weight. And that's just one part of the ERAS. So the other parts of ERAS are carbohydrate loading, promoting fluids, minimizing intraoperative intravenous fluids, minimizing surgical incision size, minimizing drains, trying to get patients up and running. So this is a small part of ERAS, but the lidocaine infusions are a big part of what we do as anesthesiologists. Interestingly, though, this just re-mentions what I mentioned before, decreases pain, infection, ileus, because it's probably an anti-inflammatory. The effects of lidocaine at those infusion rates aren't enough to actually affect sodium channels. So the thought is, how does this actually work if we're not giving enough to actually block the sodium channels? And in fact, they found that it affects polymorphic neutrophils, which is sort of the first stage of inflammatory reactions. And these cells don't have sodium channels on them at all. It also has effects centrally on the NMDA receptor and I think it's glycine receptors on the dorsal horn. And interestingly as well, it lasts longer than 5 half-lives, which is about 8 hours. If one half-life is 1 to 2 hours, the duration effect is much longer than the pharmacological effect of lidocaine itself, which is interesting. That. And this happens at low concentrations. Okay. So moving on to infusions for pain, here's a list of pain problems that are found to have, there's evidence for treatment with lidocaine infusions, including peripheral neuropathies, including diabetic peripheral neuropathy, certain headaches such as cluster headache, central neuropathic pain, including multiple sclerosis, spinal cord injury, chronic post-stroke pain, postherpetic neuralgia, certain types of cancer, particularly ones that have neuropathic pain, phantom limb, complex regional pain syndrome, and fibromyalgia. And I've got just CWP for chronic widespread pain for subsequent slides. There's a couple of good reviews. Harsha Shantana did a publication in 2012. I think he's come back from India tomorrow on lidocaine and ketamine. And this is another good publication that goes into more detail on the evidence if you're interested. It's Pain Physician 2013, and it breaks it down into types of pain problems that can respond, what's the response rate, and some of them actually break down into what certain symptoms are more responsive to lidocaine infusions: evoked pain, spontaneous pain, allodynia, dysesthesia. It's kind of interesting. This is more for people that I thought were going to be here, descriptions of what is neuropathic pain compared to nociceptive pain. So this is the IASP definitions of pain. So pain is an unpleasant sensory emotional experience associated with actual or potential tissue damage or described in such terms. And all these things, I talked about this for a couple of hours once during my fellowship and broke down this whole definition. That was Michael Cousins. And it encompasses everything in pain. So it's a sensory and emotional experience that's unpleasant, so it gets your attention for survival benefit. And I think we understand what actual tissue damage, what the benefit of that is. Potential is to try to prevent you from injuring yourself more. And the last part, described in such terms, is to encapsulate things like phantom limb pain, where there is no tissue to be damaged, but there's still actual pain that's there. And moving on to neuropathic pain, there has to be a lesion or a disease of the somatosensory nervous system. And as described above, there can be central, which is brain and spinal cord, or peripheral, involving the peripheral nervous system. So with the fellows and the residents I have in the clinic or medical students with me, I always think, is this neuropathic pain? And I always challenge, well, where's the lesion? Like, where is the actual lesion that's causing this neuropathic pain? And the question is complex renal pain syndrome or chronic widespread brain fibromyalgia neuropathic pain? And I think sometimes, but sometimes not. So type 2, CRPS type 2 for sure is neuropathic pain. I think some types of type 1 have neuropathic components. So how does neuropathic pain transmitted? What is different? So there's spontaneous activity of sodium channels either at the site of injury or elsewhere, and that's transmitted obviously through sodium channels. There's increased responsiveness centrally at the dorsal horn and expressed through NMDA. There's decreasing inhibitory modulation, GABA, serotonin, norepinephrine, opioids, and also the sprouting effect where peripherally at the dorsal root ganglia and the dorsal horn, you'll have expressions and nerves going outside of the receptive fields. That can explain secondary hyperalgesia. So if you have an injury of your hand, like say a laceration, there'll be pain outside of the area of pain, and that's peripheral secondary hyperalgesia. And then centrally, you'll have a wind up of the wide dynamic range. So interestingly, and I'm going to get to this in a second, normally non-noxious stimuli can become painful. That's usually mediated by C fibers, and that's the part of sprouting. Okay. So we talked a little bit about this. So sodium lidocaine, we're not sure how it works in chronic pain, but it's similar to ERAS. It happens at concentrations that will be less than blocking sodium channels, but there's anti-inflammatory, anti-nociceptive effects, and they reduce, for example, ectopic firing of sodium channels, but also have other effects, including peripherally on injured neurons, usually sodium channels, through depression of C fiber activity in the dorsal horn. And actually, functional MRI studies have shown that there's effects on the limbic system, specifically in the amygdala as well. Okay, so evidence. This is a busy slide. I'm just going to read it, actually. There's a couple of meta-analyses that look at effectiveness of lidocaine specifically in neuropathic pain. And this one meta-analysis found that analgesic effect for neuropathic pain of various origins and superior to placebo. Another one a few years later found weak to moderate evidence that IV lidocaine has sustained benefit for a few days after infusion, but this benefit disappears usually by 18 days. And Cochrane collaboration wrote, it's a safe drug in controlled trials for neuropathic pain, were better than placebo and were as effective as other analgesics. So not super strong recommendations from any of these meta-analyses. I'm going to get more into some evidence and some thoughts afterwards. Moving on to toxicity, and I just wanted to reiterate, the channels have effects all over the body, centrally, cardiac muscle, and so we think about seizures and dysrhythmias as a toxicity. And lidocaine and local anesthetics in general have a narrow therapeutic index. And what that refers to is the plasma concentrations where you have a therapeutic effect, and compared to the plasma concentration where the toxic effect are very close. So the therapeutic concentration for lidocaine is 2.5 to 3.5 micrograms per mil, but you start getting central nervous system toxicity at 5 micrograms per ml. True allergies are rare, and the lucky thing, to be honest, is that there's actually a wide index between the initial toxicity, which is central, and then cardiovascular toxicity. So there's warning signs of cardiovascular toxicity, which we'll get into in a couple of slides, before you'll get to the catastrophic cardiovascular toxicity. Interestingly, Pain Medicine did another review, and I just quoted them. They said, no studies have reported arrhythmias due to IV lidocaine for neuropathic pain. Another number of other publications said, most of the catastrophic issues related to lidocaine infusions were related to problems with concentration, dose, pumps, infusion rates. So it's a safe treatment. We just have to be careful with how we're doing it. So this is a nice table that looks at serum concentration and toxicity. So you can see at the bottom there, I don't have a pointer, but the first hash mark under 4 is 2. So at that level, which is therapeutic, you can also get perioral numbness and tingling. Moving on to more central nervous system toxicity, lightheadedness, visual and auditory changes, twitching, moving on to unconsciousness, seizures, respiratory arrest, and finally cardiac arrest. This was a study that did a retrospective look at 69 patients that had multiple infusions, multiple doses, multiple infusion rates, and it was looking at the percentage of patients that had an adverse effect, and 0% had arrhythmias. But other central nervous system toxicity symptoms were pretty common. So delirium was 30%. Pardon me, dizziness and vertigo was 30%, lightheadedness almost 50%, perioral numbness 25%, speech disturbance 25%. I was looking at the infusion rates on the side there, and I was thinking about my patients, and that's a faster infusion rate than we typically give. I think we do see perioral numbness and some dizziness in patients. I think usually what the nurses do is turn the infusion off or turn it down and slow things down. But the question is, what do you do if you do have a seizure? I've had 2 seizures related to pain infusions. Both were in Burlington when I was doing. One was paravertebral block, and it was probably related to dose. But the other one was very strange. I'll tell you a story. So it was a woman that had complex regional pain syndrome, and I was doing a beer block with beryllium because guanethidine wasn't available. She was a morbidly obese young woman who was well over 100 kilos. And I had a single tourniquet on her arm, and we had to pre-treat the limb with lidocaine before you give the beryllium because it burned so much. So I gave her 100 milligrams of lidocaine through that intravenous with the tourniquet up after exsanguination. So I'll just review that. So tourniquet, IV, exsanguination. Before you give the beryllium, I gave 100 milligrams of lidocaine, which was 1 milligram per kilogram, and she seized. How do you treat that? That's the question. So treatment for seizures is, first of all, stop the seizure, and second thing is support the condition. So benzodiazepines stop seizures, propofol. In that case, I used benzodiazepines. That was probably in 2008-ish. And at that time, there was all these publications, literature on using intralipid for treatment of local anesthetic toxicity. And I guess what researchers discovered that animals that were involved in studies where they're trying to induce local anesthetic toxicity, particularly bupivacaine, if they were concurrently getting TPN infusions, it was difficult to cause a seizure. So they reversed engineered it and thought, okay, well, how about we cause some toxicity and see what happens if we give them intralipid? And it aborted seizures and aborted cardiovascular toxicity. And there's a couple of theories as to why that is. One is that possibly it binds to the local anesthetic, particularly bupivacaine, which has a higher protein binding and a higher affinity for cardiac myocytes, so it's higher toxicity. But also, if patients happen to unfortunately get into the cardiovascular dysrhythmias, ventricular fibrillation, it's a high energy state, and the intralipid can give the cardiac muscle some energy to overcome and respond to the usual treatments of epinephrine and CPR. So studies have shown that there's improved hemodynamics with intralipid and myocardial perfusion. So what we keep in every area of the operating room and in the pain clinic is a bag of intralipid, 20%, and the dose is 1.5 mils per kilo bolus, and then 15 mils per kilo per hour. So the easy way to remember this is if it's a 70 kilo person, it's 100 mil bolus and a liter per hour infusion. You can do 2 boluses up to repeating the bolus up to 2 times, so a total of 3 boluses. And the infusion rate can be doubled up to 30 mils per kilo per hour, which would be 2 liters. And here's one picture of intralipid, but this is a 100 mil bag, like teeny tiny. So this is enough for a bolus dose. So you'd need a couple of liters on hand if you're actually giving somebody a lidocaine infusions. Okay, so that's it for for lidocaine infusions themselves and toxicity. So I understand that because of the volume of lidocaine patients we have, there's some thoughts about why can't we convert patients to McMaster. And interestingly, when I was a resident here, I remember Dr. Park was doing lidocaine infusions in the recovery here as a test to see if patients would be responders to local anesthetics and thinking about converting them to McMaster. And then I remember talking to him a few years later, and I said, "How's that going?" He said, "Oh, they don't tolerate McMaster." And when I started doing my fellowship, there was a dosing regimen for McMaster. That was one of the things I was given as an introductory for patients. And I said, "Oh, you guys do this?" They said, "No, patients don't tolerate it." So the interesting thing is McMaster is an oral analog of lidocaine, but it avoids that first pass of hepatic circulation. So the oral bioavailability is 90% compared to lidocaine's 35%. The elimination half-life is much longer. Instead of 1 to 2 hours, it's 9 to 12 hours. And there's no active metabolite, so it sounds great. But up to 25% of ARDS patients have central nervous system effects, including tremor, dizziness, memory loss. 40% of patients have gastric irritation, and people don't stand it very long. Mean time discontinuation was 43 days, and less than 20% of patients are continuing after 1 year. When they looked at subgroups, it seemed that younger people and males tolerated it better. So here's a figure that looks at it. So here's proportion of patients continuing McMaster after a number of days. So you can see at 3 months, there's down about 25% of patients that were started on continued, and after 1 year, there's less than 20% of patients, and it seems to be continuing to trend down. So I'm not sure how good of a treatment this would be in terms of converting from lidocaine infusions to oral. So of course, there's always contraindications to treatments. Obviously, allergies to amide local anesthetics. Patients have pre-existing heart blocks. If they're on other medications that block sodium channels or affect the cardiac conduction. Acute intermittent porphyria, it's an inborn error of metabolism where certain stressors can cause hemolysis and other effects, and lidocaine is one of the triggers. Seizure disorder. Getting back to that woman that I had that had the seizure, it turned out that she had a subclinical seizure disorder, and her seizure threshold was really low. So 1 milligram per kilogram bolus dose somehow got through the tourniquet. It was up, maybe because of her obese arm. So she had an undiagnosed subclinical seizure disorder, and she seized. And because of the metabolism, severe liver disease is probably a relative contraindication. So it's not a busy slide, but I just wanted to read this. So Canadian Pain Society in 2012 published interventional treatments for neuropathic pain, and lidocaine infusions was within those recommendations. So they wrote, in patients with neuropathic pain who have not derived sufficient benefit from pharmacological treatment, clinicians may consider a trial of IV lidocaine at doses of 5 to 7.5 milligrams per kilogram body weight for pain relief lasting a few hours to 4 weeks. Evidence quality is good, moderate certainty, strength of recommendation is grade B. And then they have some stipulations. They say, some patients with treatment-resistant neuropathic pain may experience pain relief for up to several weeks. However, and Dr. Park knows this, the response to IV lidocaine does not predict long-term responses to its oral counterpart McMaster. And there's no evidence for repeated IV lidocaine infusions. So Harsh in his publication 2012 wrote, in clinical practice, it may be looked as an additional tool for diagnostic and therapeutic management, mostly to be used in resistant or challenging neuropathic conditions when other treatments fail. And then he also commented from a couple of the studies, which I mentioned before, most studies show that, and these are my words, it's more effective with evoked pain, so allodynia, hyperalgesia, that sort of pain subtype. So this is from a different publication in the Canadian Pain Society looking at treatment of neuropathic pain, first, second, third, and fourth line. First line is gabapentinoids, tricyclics, SNRIs, and typically what I do is if they have a comorbidity, I will select one of them or the other. If they have more anxiety, I would use the gabapentinoids. More depression, I would think about the antidepressants. And if there's any contraindications to the tricyclics and they have sleep disturbance, it's something I would think about. Second line would be tramadol or opioids. Third line, cannabinoids. Fourth line are things like lamotrigine, Botox, and that's where lidocaine fits in as a fourth line treatment for these patients. So this is my approach. So if I get a new patient who comes in and I think they might have neuropathic pain, of course I do a full history and physical, including some questionnaires. We do SLANs for every patient that comes in, the LANS questionnaire for neuropathic pain. Our clinical lead wonders if there's a lot of false positives, if all these patients are actually scoring high, do they truly have neuropathic pain? And there's another tool called the DN4, which I'm going to talk about in the next slide. So let's say I've diagnosed neuropathic pain. I first try, of course, the first, second, and third line therapies if they haven't been tried before. And if after those I'm thinking about lidocaine, I think about contraindications, and I'll order an ECG to make sure there isn't any heart block. And then when they come in for their first infusion, I'll look at their height and weight and give them 3 to 5 milligrams per kilogram of lean body weight over 45 to 60 minutes with continuous blood pressures, oxygen saturation, heart rate monitoring during the infusion. And then I'll bring them back either in the clinic or for another infusion time, looking at the response either through the brief pain inventory, or there's another tool called the neuropathic pain symptom inventory, which I'm going to mention in another slide how that might be more beneficial. And then we can increase the dose up to 7.5 milligrams per kilogram. This can be done every 2 months. And lately I've been considering medication holidays just to see if they're off it for a few months, coming back, is there any difference in their pain scores? Just because of placebo effect and if we're doing multiple treatments, what's actually helping the patient. So DN4, my French is terrible. It's from France. It's the douleur neuropathique quatre, and it's 10 domains that are on this questionnaire. The sensitivity and specificities are quite good, 83 and 90% respectively. And there's both symptoms and signs. And the difference between this and the SLANs is I think there's more objective in that rather than have the patient touch themselves, we're doing a stimulus to them and asking for their response. So the first symptoms, it's self-reported, so burning, painful cold, electric shocks, tingling, pins and needles, numbness, and itching. The only confusing one is painful cold, and I didn't understand that until recently. I had a patient that came in with central post-stroke pain, and one of the pathognomonic signs is painful cold. So I took a tuning fork, metal tuning fork, and touched him, and he jumped. And so that's painful cold. Signs that we are doing in the same area of pain: hypoesthesia to touch, hypoesthesia to pinprick. That's what they read. I would think that is hypoalgesia and allodynia. And a positive DN4 is 4 or more positive responses. That's just reminding me to talk about painful cold. So this is the summation of the end of the NPSI questionnaire. An interesting thing is it breaks it down into subtypes of pain, including burning superficial, pressing deep, paroxysmal, evoked pain, and dysesthesias, which is an abnormal, unpleasant sensation, and paresthesias, pins and needles. So it'd be interesting to see if there are responders, as Harsha and other people publish, it might be in certain domains of neuropathic pain, including evoked pain, allodynia, hyperalgesia, and the like. Okay, so I'm going to do a couple of cases. I'm going to go over a couple of positive responders and some negative responders. So this gentleman is persistent post-surgical pain, 50-year-old guy. He had a complex fracture, spiral fracture of his fibula, and a complex fracture of his tibia, and was having pain after, sent to the pain clinic for management of his pain. He's a recovered opioid misuser, has opioid use disorder, and his questionnaires include a pain, visual analytic score of pain of 8 to 10, interference, which is part of a BPI, in different domains: walking, mood, general activity, ability to work, sleep, etc. A pretty high interference score of 60 out of 70. And SLANs of 19, where 12 is a cutoff of positive, indicative of neuropathic pain. So going back to the DN4, he had stabbing pains, pins and needles, allodynia, hyperalgesia, so DN4 positive for neuropathic pain. So we tried first-line therapies, duloxetine, he had a rash, amitriptyline didn't work, gabapentin caused nightmares. We didn't want to try opioids, and this is a number of years ago. This is before we actually had a lot of access to medical cannabis. There was just Nabal on it, and he wasn't interested in trying it. So interestingly, we did a first trial of lidocaine of 2.5 milligrams per kilogram, and he had profound effects. And we've gradually increased the dose to 500. And a couple of times the dose was mistranscribed, and when other people were covering for me, the dose was reduced, and he found that there was decreased effectiveness and duration. So I think this guy is a true responder. His visual analytic score went down to 3 out of 10, And although his interference scores was reduced, it's about a 20% reduction. He actually went back to school, became a social worker, training in addiction, and now he's working full-time. He just comes back for every 2 months for a lidocaine infusion. I wonder if this guy might be a McMaster candidate because he's youngish and a male. So I'm going to just broach the subject and see if we would like to try it to see what happens. So the next case is another persistent post-surgical pain. I have all these interesting patients. So there's this 44-year-old woman who a number of years ago during pregnancy had a thrombus through her arm, and she had to receive multiple embolectomies and finally had an open thrombectomy. And now she has this neuropathic pain in her arm. In the interim I saw her, she developed coronary disease, atrial fibrillation. She had acute coronary syndrome and STEMI requiring stenting. And she's diabetic, type 2, no insulin, and sleep apnea as well. When I saw her first, she came in on fluoxetine, which is an SSRI, and pregabalin. And there's her pain scores 4 to 7, interference 55, so moderately severe. S-lands of 19, and her opioid risk tool was 5, which puts her at moderate risk of opioid use disorder. Her DN4 was positive with stabbing, symptoms of stabbing, pricking. She had allodynia and hyperalgesia. So I started some trials of medications. She was already on fluoxetine, so I didn't want to add an SNRI for concerns of serotonin syndrome. She's on pregabalin. I thought tricyclic would be a bad idea with her coronary issues. And then I sent her to Greg Harrison to see if she might be a candidate for opioids, despite her opioid risk tool, and he found her to be lower risk. So we tried oxycodone, nabilone, didn't work. So she's had her second infusion of 5 milligrams per kilogram of lidocaine. She's had a profound response. So her pain scores, although it seems not to have reduced that much from 4, 7, let's say an average of 6 down to 4, her interference scores have reduced drastically. So she's only had 2 infusions, so we'll see how this goes. You know, I always think about placebo response, non-specific treatment effects, but this is a massive response. So I think I'll continue with her and see how she goes. Case number 3, another interesting guy. So I inherited this young man who is a type 1 diabetic with severe peripheral neuropathy, poorly controlled diabetes. He has an insulin pump, and one of the recorded hemoglobin A1Cs when he was here was 9.8%, so poor control. When I first met him, he was already on methadone, duloxetine, clonidine, pregabalin. He'd previously been on high-dose morphine, which was discontinued because he found it not to be helpful. His VAS was 7, interference was 42, S-land 16. So where's the lesion for this guy? EMG shows severe symmetrical sensory neuropathy with demyelination. So he's got a lesion, peripheral nervous system. So we tried first, second, third line. He's actually already on first, second, third line. But we tried amitriptyline, which he hadn't tried before. He got a severe rash. Interestingly, I thought, maybe he'll be a candidate for spinal cord stimulation. And he had some other widespread pain issues, so they said, you're not a candidate. So years ago, we started lidocaine. He's a giant. He's about 6'5", about 250 pounds. So we've been using quite high doses, and he's reported a 70% relief of pain. And sometimes people get on this train of treatments, and then it's hard to fall off these treatments. So interestingly, 2 weeks ago, this guy didn't show up for his appointment, and he's on methadone. So I called this, and he's always had consistent urine screens, showed up for his appointments. So it was very strange. His dad always comes with him. I think there's a bit of codependency, but his dad is very supportive. And so when I called the number on the chart, it was his dad's cell phone. Turns out he got sick, he turned off his insulin pump, DKA, admitted to hospital, vomiting, and he was off his methadone. They didn't prescribe his methadone. So we had to restart, and I thought this was an opportunity to have a trial with no methadone. So we're slowly weaning off. But interestingly, I was looking at his responses to lidocaine infusions while preparing for this talk, and he has good responses and bad responses for the same infusion. So good days, his VAS goes from a 7 down to a 4, and his interference from a 42. The best I saw was a 40. But other days, his VAS 7, no different, and his interference score is worse. So I think once we come off the methadone, I'm thinking about talking to these guys about a lidocaine holiday as well. This isn't about this talk, but it's interesting. I sent him to one of our other physicians who's starting ketamine infusions for neuropathic pain, and I guess one of the concerns are the vivid nightmares, and she asked something that I never would have thought to ask. Do you have any visual hallucinations? And his answer was yes. I've always had these visual hallucinations. So she didn't think he was a candidate for ketamine either. And anyways, very interesting guy. So the 4th case is my least responsive responder. It's a 56-year-old woman who has hemifacial pain after remote teeth extractions. And she's had multiple treatments with multiple practitioners. When I saw her, she was on high-dose oxyneo, hydromorphone, lorazepam. Her pain scores were quite high, interference were quite high. S-Lands was not quite positive. She had symptoms of sharp and stabbing, but no other neuropathic descriptors. And when I just touched her face, she jumped. So she definitely had allodynia. So I thought it was likely neuropathic pain. And she had told me when I first started that she had a list of medications for family failed. Topiramate, carbamazepine, pregabalin, duloxetine, amitriptyline. We tried Navalone, it wasn't helpful. And so I thought, let's try, we're at fourth line, let's try lidocaine. We did 2, and there was no benefit. So I sent her to Dr. Adley as well, and I think she didn't show up. So I'm not sure what's going to happen with her, unfortunately. So I'm going to start winding it down. The one thing is that, for example, McMaster, patients that are responsive, their visual analog score pains were reduced by 1 on a VS of 11. So, even the effectiveness when they're effective is not fantastic. And I think it's because, if we look at transmission of pain in a peripheral nociceptor, let alone centrally, if we're affecting either just this one sodium channel or if it has other effects, for example, on inflammatory cells, I think our expectations of responsiveness have to be tamed a little bit. I think the role for this is similar to all of our treatments. There's going to be patients that are going to be responders and not responders. We have to think about risks and benefits. And I think we have to expect a lot of failures and hope for the patients that are actually going to respond. So future, what I'm thinking about is, so which pain problems? Neuropathic pain, I think we have to figure out maybe which types of neuropathic pain, although there's literature on this. The question of complex regional pain syndrome, I've just started a woman who has CRPS. She had a spinal cord stimulator trial that was positive. Unfortunately, the implant didn't work. She's been through the pain program with multiple medication management. So now we're fourth line and we're trying her. She had her first Lidocaine infusion 2 weeks ago. Fibromyalgia, there's some studies that show it's helpful. Again, I think, where's the lesion in fibromyalgia? So the next thought about is what types of neuropathic pain. That neuropathic symptom inventory would maybe be able to delineate which patients would be more responsive to both pain, paresthesias. Which patients can we think about which would be better? So there's a lot of literature showing that patients with maladaptive cognitions, depression, pain catastrophizing are less responsive to invasive interventional treatments. And we have these questionnaires on every new patient that comes in. And then finally, the role of McMaster, maybe if we have younger patients and or younger male patients, there might be better responders to McMaster if they're, like my first case, gentleman who's a strong responder to lidocaine. Time for questions. It's one of my favorite pictures. That's my daughter at university, and I'm in that photograph. It's my thumb at the bottom left there, the smudge. I'm not in the suit. No. I'm not that much of a nerd. How about that? Okay. Questions? Any questions online? No questions online. Joe.
Thank you very much for excellent video. This is excellent. So after reading all that, in terms of the few questions that so when do you? I know that it doesn't last that long.
Yeah.
It's just sort of fourth line of neuropathic. You try once, and when do you decide that you sort of subject the criteria?
Well, I think
10 days.
Well, I think it was what I found is that we start at the low dose, and if there's any, usually if there's no response, I'll increase the dose and see what happens, expecting no response again. But if they have a partial response or a short response, then I'll increase it up to 7.5 milligrams per kilogram. And a lot of the studies show that it can last. Beneficial effects can be up to 28 days, up to 4 weeks. And unfortunately, we can only really do it every 2 months. And I tell patients, this might only be helpful for 28 days or a month. But for example, my first gentleman, if he's late by a few weeks because of scheduling, he notices a difference. So I think there's obviously, like any of the treatment, there's positive responders and strong responders and people that are equivocal responders. I think that's why these questionnaires are probably good, and lidocaine infusion holidays are probably good too. Because if you do a questionnaire sometime after they have the infusion, give them a holiday, bring them back and see what their pain scores are. If there's a big discrepancy in their pain, I think you have evidence of some sort that it's doing something to help them, particularly the interference score. If they're able to do more, then I think it's something we should continue.
No, let's say, for example, you try one treatment in your mind,
Yeah.
Would you do it 2 times?
At a different dose.
I'm sorry.
Sorry. So the question is, if you have a test or a first trial that's a non-responder, what do you do afterwards? And my answer was, I think we increase the dose. So we can go, if we start at a test dose of 3 milligrams, go up to 5, maximum dose is 7.5 milligrams per kilogram. I always think about risk and benefit of the patient, and if there's no response, for example, that last patient, we did 2 doses at 5 milligram per kilogram, and there was no response, and now I wasn't going to increase it. With 0 response at 5 milligrams per kilogram, I think it's pretty reasonable not to try a third one at 7.5.
Second question is that given the fact that the potential cardiac toxicity or is more in terms of monitoring.
Yeah. So the question was cardiac toxicity and ECG monitoring. You know, it's funny. So when we in Australia, they would run ketamine infusions on the ward without monitoring, and they would run lidocaine infusions on the ward without monitoring. And what they would do is they would do an ECG before, and they would do plasma concentrations the day afterwards to see what the concentration of lidocaine was. And I know it's funny that you're involved in CPSO and monitoring in terms of cardiac. There's nothing in literature that said it was a requirement. I think if you have heart block on ECG, preoperative ECG, then I think it's probably relatively not absolutely contradicted. Sorry. And if they have, I think we can safely with a pulse oximetry, and with the difference in toxicity of plasma concentration being so great between CNS toxicity, peripheral numbness and tingling, and to the point of cardiac toxicity, I think we're safe not having ECG monitoring. Because the thing is, too, is who's watching the monitor? You don't have an anesthesiologist there watching the monitor. And although nursing might have, unless you're an ICU nurse or a CCU nurse, the warning signs of maybe an occasional PVC or prolonged QRS, all these things are pretty subtle. It's like putting a Swan-Ganz catheter in. If you don't do Swan-Ganz catheters all the time, and you put one in, interpreting the data can be difficult. So I think unless you have somebody, I think the monitoring is only as good as the person who's interpreting the monitor. Do you know what I mean? John?
So I just have a couple of comments. I have one question. When you were in Australia, did they do a little?
No, there was a trial when I was there for lidocaine for post-herpetic neuralgia. They didn't have many patients. There were about 4 or 5 patients.
Because I have to admit, I'm British trained. I have to say that it was like one guy, one did it, and that was kind of like everyone kind of looked at it.
Yeah.
Kind of like, do you have any, don't know about open X-ray, something like that. But then when I came to Canada and I went to Ottawa, we were doing like 6 a day. I was just like kind of those were always a bit like kind of shocked.
It'd be interesting to do with the rest of Canada, because I think Ontario is a lot more interventional, for example, than when I was in Alberta. They're sort of moving away from interventional. I don't think BC is that way. I think BC.
So that's what I'm saying. So I was just saying in Ottawa, they do have a protocol for lidocaine for keeping it. And I was just in St. Paul.
Yeah.
And they have a large tolerant station. So for keeping, they have ketamine.
Yeah, and they don't, on running lidocaine and ketamine infusions at work, they don't have to have cardiac monitoring.
No, and they're running both of this.
Yeah.
Right.
So, yeah.
But one other company that mentioned is one of the other experiences I had in Vancouver and St. Paul is about subcutaneous lidocaine. I just mentioned it sometimes already. Because they can, the chronic pain team only had capacity for one IV lidocaine. So they would use dialysis package, and then they would start them to substitute.
So would they do elastomeric pumps, or would they have?
It would be running 5 mils an hour.
Huh. The one thing, so my program director when I was in Australia was a bit of a pedantic curmudgeon, I would call him, and he had a patient that he was always raving about. The poor patient had an obstructive low brainstem lesion causing hydrocephalus and neuropathic pain. And with the help of neurosurgery, they did an intracerebral CSF lidocaine infusion, and the patient response was apparently massive. So, I think there's a role for it. I wouldn't want to put in a BP shunt with lidocaine infusion in my head, but I think there's definitely a role for it, for sure. And, yeah? Jeffrey?
You mentioned ketamine a couple of times. One of my clients did get that. East side of the plant, and what was on there, they were being lidocaine on their face. They had the 10 milligrams of ketamine. It sort of boosted it. I don't know the 10 milligrams. But they get to be using quite a lot.
Yeah. Yeah, I know the clinic. Yeah. I think they're transitioning more from even higher dose of ketamine. And we're thinking about it here. We're starting up a trial. Dr. Adley is trying to find patients for ketamine infusion. And actually, Dr. Santana at our institution, he's doing a study for using ketamine transitioning onto amantadine, which is an oral NMD receptor antagonist for thoracic pain patients, and then looking at chronic pain afterwards. It's funny. I had a couple patients in Burlington that I did ketamine infusions on, and one was a nurse that had a fall injury of her hand, bad CRPS. She had a strong. I did so many stellate ganglion blocks on her, and eventually we tried ketamine, and it worked like a charm. And she would come in for monthly ketamine infusions, and we transitioned her to amantadine, and it worked great. Other patients, the woman I have transitioned from Burlington to here. She has a lot of psychological and psychiatric diagnoses, and we tried ketamine, and the delirium was she couldn't tolerate it. And so she's on lidocaine now, having variable responsiveness, unfortunately. So for example, this young guy who has the diabetic neuropathy, if he was to have delirium or the unpleasant dreams and he was in the clinic, it would probably be bad in a lot of ways for a lot of people because he's such a big young guy that I don't think it's a candidate. So I think there's a role for it, and there's evidence for it as well. That one publication that I did in Pain Physician 2013 went over the evidence for it in subpopulations as well. And Harsh's if you look, Harsha Santana, I think the title was Lidocaine Infusions or Infusions in Pain Medicine. Anyways, I can get to you afterwards. He went over the evidence for ketamine as well. So there is evidence for it in specific pain problems. Okay. So this is from Janice Sumpton. In your clinical experience, do you try 2 infusions, Q8 week, or 3 infusions? Do you give more frequently than every 2 months in select patients? So the first question was, in your clinical experience, do you try 2 infusions every week or 3 infusions? So I would do it every 2 months, and I don't do it more than frequently than every 2 months for a couple of reasons. One, it's medicalization, so we're medicalizing patients more, so if they have to come to us for more treatments all the time, then they get on this hamster wheel of, you're going to fix me, I'm not going to fix myself. So if we did them weekly or monthly or bi-weekly or bi-monthly, it's just more intervention. So I think the more we minimize these things or make them less frequent, the better. And then reimbursement, the OHIP doesn't pay us if we do it more than 6 times per year. So you can do it every 2 weeks if you want to, up to 6 weeks total. Up to 6 times total, sorry. I hope that answers Substan's question. Anybody else?
Okay, thanks very much, Sean, and thanks very much those folks on the WebEx. Much appreciated, and we'll see you next month, I think. What's on next month, Joe?
Next month's topic is actually very interesting.
Yes.
This one.
What is it?
Pain management of patients who have.
Okay, yeah, good point. So Roman Jovi, next month we'll be talking about pain management in the patient with addiction. So sign back on. The notification will come around as usual. Take care. Thanks again, Sean.
No problem.